you to introduce Dr. Romero, if that works.
Yep, and Dr. Romero, I will make you a co-host right now. And so at the bottom of your screen, you should see a share screen with a green square.
Great, and I turn that on after Dr. Wheeler finishes?
Yep.
Okay, got it.
All right, I think Dr. Wheeler, you can go ahead. Thanks, everybody. This is our last CME and MOC session for the conference, and we will follow this with our business meeting. But at this point in time, I'm going to turn this over to Dr. Wheeler to go ahead and introduce Dr. Romero.
Thanks, Anna. And again, thanks, Katie, for wonderful logistics. I get the opportunity to introduce my friend and colleague, Dr. Romero, who will be doing the last scientific session today. Dr. Romero and I met almost a decade and a half ago. It's been that long. He came to take over the section of infectious disease in the Department of Pediatrics at UAMS. And my first exposure to him, I think, was when he was being introduced by Dr. Jacobs, who was chairman at that time. And he did this wonderful Daffy Duck kind of commentary they used to do with the kids. And at the time, I didn't know quite what to think, and came to know that Jose has some kind of internal calm that I don't fully understand. After we worked for quite a while together, I'm going to take partial credit and partial guilt for visiting with Dr. Nate Smith, who was the former Secretary of Health at the Arkansas Department of Health, who mentioned that he had a conversation with Jose about coming to the Department of Health to work. And I thought that was fabulous. At the time, I was the chief medical officer, and it was suggested that Jose might be interested in that. And he came over, and I sort of stepped aside and began my retirement plans. It was really an interesting period. I think the first day he came over to sort of shadow to find out what this chief medical officer did was our first case of COVID. And I think you all know the rest of the story from that point on. He stepped into that role with both feet. And then shortly after that, Dr. Smith announced that he was moving to the CDC. And Dr. Romero was asked to be the interim Secretary of Health. And in August of last year was commissioned as the full-time permanent Secretary of Health. Prior to doing that, he had some wonderful training through the ACIP, which is the unit at the CDC, made up of a wonderful group of volunteers who craft and develop vaccine recommendations for the United States for children and adults. And in that role, he was in another critical position of having to weigh the benefits and side effects of COVID vaccines. So this is, I can't tell you how heady that work is, how difficult that work is, refereeing the incredibly strong egos of the people who are on those committees, balancing that off across industry, politicians, and everyone else. And he did it in a remarkable way. And then had on top of that burden was added the role of being Secretary of Health for the department. And I have to tell you, I would have crumbled under that weight. And Jose has somehow magically continued to do it. I don't know whether he runs those little Daffy Duck comedy strips in his head, at the beginning of each day as an alternative to meditation, but he has been incredibly successful at carrying some very, very heavy mantles. Because of his background, which I should mention as an investigator in enteroviral disease, which he did in the early part of his career and has continued to be involved in clinical research, he's been the right person at the right time to lead the state and lead the nation in his roles. And we couldn't have a better person who could be here today to speak on COVID and vaccines and give us an update. And Jose, we really, really appreciate you being here. We appreciate COSI's role in supporting you through this incredible process, and look forward to hearing your insights. Thank you.
Thank you very much, Gary, for those very kind words. You know, it just goes to show that I'm always following you. You know, you were the interim chair of Peds ID, and I followed you as chief of medical officer at the health department. So keep blazing the trail, and I'll keep following you. Let me go ahead and put this in, and thanks to Katie, who was very patient with me getting all these in and shepherding me through this. So here we go. So I'm going to talk about COVID-19 as a pediatric update. I'm going to talk about the vaccines that are available, the vaccine that is available. But I really want to give you an in-depth view of what COVID is like here for us. We hear about what it's doing in other states with regard to pediatrics, but I want to give you really up to the date, up to the minute data on this issue. So let's see if I can forward this. Okay, here we go. Okay, so I have nothing to disclose. I think no financial interests whatsoever. So again, quickly, the structure of SARS-CoV-2 virus. This is this picture I think you've all seen. This is a virus that has, the gray here shows a lipid membrane. Studied in this membrane are a number of proteins. And the real one that we're going to be interested in, the one that really is the focus, is this S protein, or the surface protein shown here in red. It studs the entire surface along with two other minor proteins, the E protein and the M protein. And if you split this open like a tennis ball, what you'll find is that these proteins actually pass through the membrane into this internal portion of the virus. And then inside here, there's an RNA molecule, a positive sense mRNA molecule that is studded with proteins called nucleoproteins. And those can be used for diagnostics, so we won't spend time on that today. So this is a cartoon from Nature. It shows the spike protein, and the spike protein is actually three pieces. It's a trimer that is put together to form this one solid molecule. And so this is three pieces, and you can see here there are different colors. And the protein actually exists in what's called a metastable form. That is, that it has the capacity to move. And when it comes near or in contact with its receptor, the ACE2 receptor, an arm folds out and exposes a receptor binding site, or known as an RBD. And this will be important because I'll talk about this with regard to the vaccine. This RBD then binds to the ACE2 receptor, and you're off to the races, because then tectonic changes occur. This virus is pulled down, and I'll talk about this in a minute, and allows the virus to begin its replicative cycle. So antibodies that protect against SARS-CoV-2, COVID, actually work because they attach themselves along these proteins and prevent this receptor binding protein from, or the receptor binding site from, interacting with the ACE2 inhibitor, and in particular the spike protein's tip, the RBD. I want to shift gears now to talk about the newest problem that we have with regard to the COVID virus. That is, the SARS-CoV-2 has generated over time, as would be expected with an RNA virus, variants. And the variant that is most concerned to us now, and I'm not going to talk about all the different variants, but I'm going to talk about this one in particular, is the Delta variant that was previously identified as the India or Indian variant. It arose in India during this massive upswing in cases that occurred early this year. It's called a double mutant because it contains two mutations at position 484 and 452. These are the changes from an E to a Q and an L to an R, and they're shown down here. I think my pointer shows through, but if not, it's on the lower part. These are the two mutations and the double mutation that it's called. So it has lots of different names. The World Health Organization gave it a new name called the Delta, and that's how we refer to it. It's become the dominant virus here in the United States, the dominant variant, and also in Arkansas, and I'll talk more about this. This this E484Q is in the same position as another mutation, and it probably helps to evade some antibodies that we have. The D614G mutation here, shown in this site, enhances infectiousness and transmissibility. And then this, as we climb up, you can see that there are other mutations. There's a P681R, which enhances the ability of this virus to fuse its cell membrane, its lipid membrane to the cell, and increases pathogenicity. So what does this translate to in the real world? So there's definitely increased transmissibility. This virus is more transmissible than the alpha virus, which was already more transmissible than the ancestral or parental strain, if you will. So this is thousands of times more transmissible than the original coronavirus that arose out of Wuhan. There is a potential for some reduction in neutralizing monoclonal antibodies, and I'm going to talk about that, and I want you to keep that in your mind because it explains why you can't use some monoclonal antibodies. There's a potential for reduction in neutralizing a post-vaccination sera, but it doesn't affect very much the Delta virus. It does affect others, and I'll talk about that too. And then there's a potential for increased pathogenicity, which is what we're beginning to study now. Children's Hospital, children from Arkansas are part of this. We're submitting data from the health department to the CDC regarding this issue. And we'll talk a little bit about that. Okay, so Delta raised its ugly head really for our surveillance purposes in March of this year, May of this year, excuse me, towards the end. And within 6 weeks, shown here in the arrow, it became the dominant strain. And I will show you graphs that follow that show the dramatic shift in the number of cases that we had. Really between February and March, I really thought we were over this. I thought we were going to be done. We might have an uptick in the winter, but I was shown to be wrong. At this time, this virus represents nearly 92% of all the variants identified in Arkansas, and you can see down here on the bottom. So 800 submitted for sequencing, 732 turned out to be Delta variant. So this is of the variants, and it's the number one virus, variant in the United States. All right, so let me walk you through these graphs. So the blue lines represent 2001 cases, and then what we're looking at here are individuals hospitalized during 2001 and 2002. So you can see that we had our first case in March, and that was just amazing that I was following Gary, and literally we had the first case that day. And I'm juggling on this, right? I mean, one call after another. We can see here the rapid increase. So we've had, several spikes, right? We had this spike, okay, and then it sort of leveled off, and then it took off again. And so, as you can see, this is blue. And then if you flip over to the other side of the slide, you'll see this year, which is in red. And we peaked in January, right, at this level. So these are the individuals hospitalized, okay? And you can see we had a steady fall. And I really thought we were over it during this period of time. But remember that Delta became predominant in this state, okay, in June and July. And you can see now, here is the upswing of all hospitalizations in the state. We reached a peak. We seem to be trending down, but I'll tell you, this is a false sense of security because our patient base is going to supply many more cases in the near future and is going to serve as a nidus for spread of this again into our community. In addition, guess what's coming up next weekend? Labor Day weekend. And every time we see a holiday, we see a spike. So I expect to see more cases in the few weeks. We are not out of the woods yet. Let's see if I can get the kids up here. Okay, so this is the 7-day rolling average, okay, of children or adult pediatric patients 0 to 8 years of age. And again, the blue shows the swing upward, okay, upward to the end of the year. It peaked out here at about 475, 480 cases, okay, and then it fell rapidly, right, and looked very good. But again, when Delta shows up, the cases have rocketed upward. And if you look at the time it's taken to get to the maximum number and compare it to how long it took us last year, you can see that this is spreading very, very rapidly. And we have indications that this will be a significant burden in school from the summer because we were seeing cases that resulted in closure of daycares and closure of summer camps, something we didn't see last year. And let me go forward one more. Again, this is pediatric data. So these are the weekly hospitalizations, okay? And you can see that the weekly hospitalizations peaked in December, about mid-December, at about 28 per day. And you can see that we have eclipsed that now. Now we're going down. Some of this probably has to do with the fact that kids are back in school. They're not playing around. They're not transmitting it that much. We're not seeing kids getting hospitalized. But I think we're going to see this go up again. So again, as I said, I want to give you the data for kids. I want you all to understand what it is, because your parents are going to be, the parents are going to be asking us this question. So this isn't a numerical table, it's in a tabular form, but you can see that you know, the largest number up until January was the number of cases we saw in the ICU were 11 with 2 on ventilators. But in July, we shifted. So 17 cases of children in the ICU, 8 of these were on ventilators. And in August, and we're not done with August yet, we're at 11 and 3. And in talking to Steve Scheckschneider, the chief of critical care medicine, these kids are not Miss C kids. These are kids that are having direct pulmonary insult. So they're not showing up 48 weeks after, sorry, 4 to 6 weeks after the spike, like we are normally seeing for Miss C. This appears to be direct pulmonary insult due to the virus. And it may have to do with that, you know, that slide which I showed you about increased pathogenicity of the Delta virus. Again, here it is now in graphic form, but you can see really that this is shifted now. So this is the number of ICU admissions 0 to 18 years of age. You can see the has really picked up over here, you know, and again, the number of individuals on ventilators. Added to this are the number of individuals on ECMO. So we have more kids on ECMO this year than we have had in the past. And we've had 4 deaths to date in the pediatric age group. We're investigating another death at this point, but 4 deaths so far. All right, so what are the key data points for you to jot down? We've had nearly 69,000 cases of pediatric disease in the state. As of the 27th, so as of yesterday, look at this, 26% of all the active cases in the state are pediatrics. That's unheard of. Right? And if you look at that, okay, 0 to 11 years old, 16% of all active cases, right? So kids are starting to pay the brunt of this. And I think that I'm going to see this number go up even further. And I think it's going to hit 1/3 of all cases. Now, remember that this group, this 0 to 11 group, can't receive the COVID vaccine, right? And masking is really the essential physical deterrent for infection and spread. And that's why masking is so important for these children. Between April and August, again, startling numbers, you know, a 2,500% increase in cases less than 18 years old, you know, 2,600% increase in cases less than 12 years old, and an increase of nearly 450% in hospitalizations due to children less than 18 years. And this may be because we're seeing more infections. We need to sort that out. The CDC is working with Children's Hospital and a number of children's hospitals across the South in order to sort that. Okay. Also, so among kids less than 18 years of age hospitalized in August, okay, two-thirds were less than 12 years of age. So these are going into the hospital, right? And more children less than 12 years of age were hospitalized in August than in any of the previous months before that period of time. And hospitalizations for children less than 12 years of age increased by 750% since April of this year. Right? And these are startling numbers for us. The ICU admissions are shown here, you know, 275% increase from April to July. And of the children entering in July, okay, again, 80% of these were 12 to 18 and 20% were less than 12 years of age. And you know, what Steve Scheckschneider is telling me is that one of the major risk factors he's seeing for kids going on ventilators is obesity. I mean, kids that are obese are the ones that are really winding up on these ventilators. And we'll talk about that in a minute. Okay. Let me give you the school data. So this is school data as of Thursday. So we run a school report on Mondays and Thursdays. Mondays, they tend to be lower numbers, and on Thursdays, they tend to increase. So remember that we're only, what, 2 weeks into school, maybe? Some places are longer than that, but so we had as of last Thursday, 3,352 active cases in K through 12 schools. This was an increase of over 1,200 cases from Monday. And the major counties, and I'm not throwing stones, this is out there for the public to see: Bentonville, Springdale, Rogers, and Cabot. Okay, 173 of the school districts report at least 5 active cases, and that is an increase of 44 since Monday of last week. Now, I want to tell you about something that you already know. There's an act that was passed this year. It's Act 1002. It prohibits the issuance of mask mandates by myself or by the governor, and really my authority is through the extension of the governor. He has to approve everything, so he cannot do this without the legislature agreeing. It does not apply to private businesses actually, I think I wrote this right. So this actually does not apply to private businesses, and it does apply to state-owned or state-controlled healthcare facilities. So you can see I'm not getting enough sleep. So it does apply to state-owned and state-controlled healthcare. It does not apply to state healthcare controlled facilities. And so that's why we have this prohibition of masking in the state. And as you all know, that is enjoined at this point as it undergoes a legal challenge. Okay, so vaccination of children. So here are the graphs for vaccination of children. And so this is the status as of yesterday. So you can see that this is the curve. These are the individuals that have received at least 1 dose here. This is when Pfizer-BioNTech became available for 12 to 15 years old. Before that, it was 18-year-old primarily. And then here are the individuals that have completed the series. So at least 1 dose, nearly 44% of our childhood population that can receive it, and 28%. So we have a long way to go. Immunity or herd immunity, if you will, although you've heard that that's fallen away, right? We're not talking about a herd immunity anymore. But what we want to see is large numbers of individuals immunized. We think that we probably need upwards of 80 to 90% in order to limit or to stop spread in the community. All right, vaccines. So this is the status of vaccines in the United States. There are 4 or 5 vaccines, that are either approved or under clinical trials or have completed clinical trials. Most recently, there is a single vaccine that has undergone full FDA approval for use. Okay. Now, this BLA approval is only for children 16 years and individuals older. For the 12 to 15-year-old, hint, hint, this could be an MOC question. Okay. For kids 12 to 15 years old, it is still under an EUA. All right. It's a BLA above, not below that age. So this is an mRNA vaccine. We'll come back to that in a minute. Vaccines that have EUA approval to date continue to be Moderna's vaccine and the adenovirus vaccine by Janssen or Johnson & Johnson's vaccine. 2 other vaccines are either in active or completed phase 3 trials. They are the adenovirus vector from Oxford, University of Oxford, and a partnership with AstraZeneca, and then the protein virus vaccine by Novavax, and they're going evaluation at this time. All right, so the key study is for children. This is the key study for adults. Again, this is the new name for this vaccine. So here, this is an mRNA vaccine. It's a lipid nanoparticle. This mRNA is wrapped inside a little ball of lipid, and I'll show you that in a minute. And it's trimeric. It has 3 pieces of the protein joined together of the binding site. So it's the binding site that's eliciting the immunity. Doses are given at 0 to 21 days, and studies in adults show that it had 95% of efficacy in clinical trials and has extremely high efficacy in effectiveness, in the real world. So the EUA was approved, okay, for children 12 to 15 years old, hint, hint, MOC question. The VE, okay, against hospital related deaths and for hospitalization and deaths is 100% for children. And I'll show you that in a minute. It continues to have good VE against the UK or alpha variant, but those changes that I showed you on the molecule itself are leading to decreased VE vaccine efficacy against the South African beta strain and the Brazilian strain P1. And again, this protects adults against hospitalization and death from the Delta variant. The other important piece, hint, hint, is that remember that you can administer this vaccine to your adolescent patients and also administer at the same time flu vaccine, the HPV vaccine, other vaccines that need to be given so that we can bring them up to date and keep them current. Okay, quickly, how these vaccines work in case parents ask you this question. This is from the New York Times. I've just cut it up and shown it in pieces. So I love their cartoons. So these vaccines have the genomic sequence in mRNA form of the spike protein in a lipid nanomolecule shown here. So it's in a little ball. This is very similar to what we use, for example, in the case of HPV vaccine. It's just a shell, right? There's nothing inside of it, but this one does contain the mRNA. So these two lipid molecules, this lipid molecule will meld with the lipid of the cell, the host cell, and will allow the mRNA to be dumped into the cytoplasm. Once that happens, the mRNA finds its way to a ribosome, and there at the ribosome site, it is translated into protein, okay, at the site of the endoplasmic reticulum. This is dumped in there, and you form a spike protein from one of these guys. Now remember, this is a trimer, right? So there's three pieces. So three little spike proteins come together to form a big spike, and then these form here in the cytoplasm, or really they're actually in the lumen of the endoplasmic reticulum. They stick into the cell membrane because of their characteristics of attachment to the membrane. There's also some pieces and parts because this synthesis is not exactly full. And so you wind up having presentation of these full spike proteins or spike receptor binding sites, as well as pieces that are being presented by the major histocompatibility complex. And then these are seen by the immune system, and Gary is a trained immunologist, so I will not try to tell people how this works, but the immune cells see this and make lots of antibodies and make very good antibodies to this. So the phase 3 trial for 12 to 15-year-olds is summarized here. It was relatively small, but at the same time, they used bridging data to young adults in order to show that this data is comparable. And, I think we all understand that, really kids 16 and above, maybe 12 and above, they're not really, our garden variety little children, right? They're physiologically more like adults. So a lot of the data we can translate, we can bridge to adults. So this 2,260 subjects, approximately half received the vaccine, half were placebo. And the correlates of protection included immunobridging using the geometric mean titer ratio, a response, a greater than 4-fold rise. My connection is a little unstable. I'm sorry about that. From disease, symptomatic or asymptomatic. And as I said, this is a completed study. Went before the UA approval in May. Full ACIP review later. So let me show you some of that data in case you're asked. The mean geometric titers during the trial, and as you compared between the 12 to 15-year-old group and 16 to 25-year-old group. And you can see that day one, there's virtually no titers, right? Because they're not infected and they haven't been vaccinated. By day 52, that's 1 month post second dose, the titers were about 1,300 in the vaccinated group compared to 15, so essentially unchanged from the placebo group. And as you can see, they actually had better titers than the 16 to 25-year-old group. And that's not unusual, right? We see the same thing for HPV. Younger patients seem to have much better titers. They have those vaccinated had better placebo group. If you move on to the mean geometric titers, so again, non-inferiority was compared when you compare the 12 to 15 to 16 to 25-year-old group. Non-inferiority is declared the low boundary of the 95th percentile confidence level is greater than 0.62. Here is the titer, which was slide, the number of individuals. And then if we fast forward, no surprise, yes. So the confidence interval was met, and therefore there's no inferiority between the two groups. The vaccine is effective in generating good neutralizing titers in the population study. They took all individuals, they took individuals, so 143 12 to 15-year-olds, 124 16 to 25-year-olds, and they asked the question, how many of them had a fourfold or greater rise in antibody titer? So in the 16 to 25-year-old, it was 100%. In the 12 to 15, the confidence interval was met, and therefore it's equivalent to the older group. And so this functions as well in the younger group as in the older group. All right, and then so what we're looking at here are action, right? And so what you can see is that the first COVID occurrence from 7 days after the second dose, because that would be considered now person to be fully immunized, that received, and in the group that received the placebo, there were 18 cases. So again, from effectiveness or efficacy, you can see that it is there is efficacy in the study population. All right, side effects. So really quickly, I won't spend a lot of time on this. I'll tell you that if you look, so here's dose 1, dose 2. A placebo group is here. The age group that received the vaccine is here. Okay, this is the 16 to 25-year-old group. And as you can see, there were the usual things. So some redness, some swelling, of course, pain at the injection site. You're getting a shot. And so you can actually see that that the incidence was about the same as what you're seeing with the older group. The same when again, you saw systemic reactions such as fatigue and headache, very similar to what you were seeing in the 16 to 25-year-old group. In the 12 to 15-year-old group, and again, you can see some less muscle pain after the first dose, but very similar. And again, this is after the second dose. Again, very similar, a little bit more fever again. What was interesting was that you had less muscle pain, a significantly decrease in the number of kids that had muscle pain compared to 16 to 25 years old. So very similar. They did note lymphadenopathy, and some parents may actually call you and tell you, my child has swollen lymph nodes either in the axilla or in the cervical chain on the same side, the ipsilateral side that they received the vaccine. That's not unheard of. In the adult study, it's very, very low. It tends to be here in the study, it was on the left side because that's where the vaccine was given. The onset is 2 to 10 days after infection, vaccination, excuse me. And the duration seems to be about 1 to 10 days for those cases reported. Others were still ongoing at the time of cutoff. And it makes sense, right? I mean, if you have a scratch or a small infected site on your hand, sometimes your epitrochlear node will swell up or your axillary node will swell up. It is an immune response located in the draining nodes from the site in which you were inoculated. So this is not unusual. There really isn't a point to be concerned about. Okay, so reactogenicity. Overall, this was well tolerated. This is the take-home slide, if you will. In 12 to 15 years old, the reactogenicity was very similar to older patients. The predominant signs and symptoms were fever, pain at the injection site, fatigue, headaches, chills, arthralgia, and myalgia. Now, overall, the adverse effects were very similar. We talked about the lymphadenopathy, and during the study, there were no serious adverse events, but I do want to talk about that in a minute, and no deaths. All right, so as you know, as I've said many times before, the US vaccine system is the safest in the world. And it's the safest in the world because we have in place a number of mechanisms by which we can either report or monitor adverse events. And they've served before to identify problems. So the rotavirus vaccine, we identified the possibility of intussusception. We can see these events occurring, and we can act by evaluating them and issuing recommendations. So what are the side effects, the serious adverse effects that have been identified? So anaphylaxis, right? Shortly after Pfizer-BioNTech rolled out their vaccine, we started to see cases of anaphylaxis. We also see them with Moderna. So overall, the incidence is about 4.7 cases for the Pfizer-BioNTech, 4.7 cases per million second doses. And for Moderna, it's 2.5 cases per million second doses. The median age, for each study, so for Pfizer-BioNTech is 39 years of age, for Moderna 41 years of age, so about the same, 41. And this is the age range. So we may see this. We have to be prepared for it, just like we are for every vaccine, right? We should be able to react quickly to deal with these problems at the sites of immunization. What is also being followed are cases of myocarditis. These tend to be in younger individuals. The overall incidence is 3.5 cases per million second doses, but it is higher in young males between the ages of 18 and 29. And we're looking at whether this is the same in these children from 12 to 15. So in that group, in 18 to 29, it's 24.3 cases per million doses. Now, the CDC has done a benefit risk analysis by asking the question, how many cases of COVID will you prevent? How many cases of hospitalization will you prevent? How many cases of ICU admission will you prevent? And how many cases of death will you prevent? And I don't have the time to talk about that today, but the slides show that for the age groups for which it was parsed, the benefit risk ratio falls in favor, clearly in favor of use of this vaccine in that population. And we will continue, not we, I have to stop saying that because I'm no longer on the ACIP as a chair. I sit on their vaccine group, but I'm not a voting member. So they will continue to evaluate this as we go forward. But parents may ask you about this. What do we know about it? It's generally very mild and self-limiting. You don't have to treat it. Most of these kids don't have to be hospitalized. So it seems to be mild in nature and self-limiting. And also remember that by itself, COVID-19 can cause myocarditis, right? Myopericarditis. So you need to tell the parents about that also. And that was also in the evaluation of benefit risk. Okay, so contraindications. As with any other vaccine, if you're allergic to any of the components of the vaccine, you shouldn't get it. Now, one of the questions that the governor and I get when we go out to do these town halls is, what's in the vaccine? It's being held secret. We can't get a hold of it. It is easy to find. And if you need it, it's on our website at the health department. Pull it up, print it out so the parents can give it, can study it. If you are allergic to polyethylene glycol or to polysorbate, your patient should not receive the vaccine for fear of anaphylaxis. All right, some warnings. And I think I'm going to leave enough time for questions. But so this is something that came out very, very recently, and I'll give you the background. So as the ACIP, and I can say we here because I was a member of the ACIP at the time, as we began to see that this vaccine was going to possibly be BLA approved, what we got word of from our CDC partners was that there was chatter on the websites, right, social media, that some physicians, and it was picking up steam, were thinking about giving half doses of the licensed BLA vaccine to children under 12 years of age because there's no vaccine for them. Now, that is a dangerous, unproven method of using the vaccine. And so that prompted this reminder that those of you that are administering the vaccine have actually signed an agreement, and that you need to follow that agreement, and that use of these vaccines, right, unlike medications, right, where you can use off-label, right, and we can talk about ivermectin, we can talk about hydroxychloroquine, we can talk about all these things, right? This is not recommended, right? Not recommended. And if you do that, you will violate your provider agreement, and you could expose the providers to the following risks, right? So beware, right? Here you go. So it will not be covered under the PrEP Act or the PrEP Act declaration, and therefore the immunity provided to providers, that's a horrible sentence, accorded to providers, okay, is not going to be there, right? You could get into big trouble if that child has a reaction. Individuals who receive off-label doses, this is very important, are not eligible for compensation under the countermeasures injury compensation program for possible side effects, right? So your patients then can't get reimbursed for care or liability, right? Okay. Provider agreement, okay? And it may impact your ability to continue within the CDC program. So what is that? Vaccines for children. Okay, you could lose your privilege to participate in the vaccines for children. And administration fees may not be reimbursable by payers. Payers may say, heck, you gave it out of accordance to the indicated populations. We're not paying for this vaccine. All right, now I just want to end with 2 slides. Those are on monoclonal antibodies. So these are particularly important for adults because this is what I think is going to help us keep from teetering over the edge. These monoclonal antibodies are against the spike protein. They have been shown to reduce hospitalization anywhere from 70 to 85% in individuals who receive it within a 10-day window of acute onset. It's now been approved for children, for pediatric patients, again, greater than or equal to 12 years of age, weighing 40 kilograms with outpatient mild to moderate disease. And again, this goes along with that idea that, that once you get to be about 12, your pathophysiology, your physiology is more like an adult than a child. So these are the monoclonals that are approved, right? And I won't even try to pronounce them because I get tongue-tied every time I do. But what's important to keep in mind is the bottom 2, bamlanivimab, and its combination with etesivimab, no longer used right now in the United States. And the reason why is, go back to that first cartoon that I showed you. There are mutations in the Delta, not in the Delta, excuse me. There are mutations in the P1 variant and in the alpha variants, the beta variants, that make these less effective. And so for right now, this is not being recommended to be used. These are the ones that are being recommended. So here you go. So it's indicated for those kids greater than or equal to 12 years of age and meeting the weight requirement. Again, these are the risk factors overall. So obese, if you're over 65 years of age, which our kids aren't, obesity, okay? And if you're a child, that obesity is defined as for 12 to 17 years of age is above the 85th percentile for age and gender. And remember, this is what Dr. Scheck-Snyder is seeing in his intensive care unit, right? These are the kids that are winding up on ventilators and going on to ECMO. So diabetes, it's any type of immunosuppression, heart or lung disease, chronic kidney disease, sickle cell disease, neurodevelopmental disorders. I would like to make a special plug for Down syndrome or trisomy 21. We know that those children are particularly at risk for significant disease. If you have medically related or medical related technology dependence, a tracheostomy, gastrostomy, positive pressure ventilation, that's not related to COVID-19 or other medical conditions. So race and ethnicity, right? We know that that among African Americans and Latinos, there's a greater rate for significant morbidity and mortality. I ask you to turn your attention to this site. This is from the Minnesota health department. It is an outstanding reference. It actually goes down and talks about what specific conditions as congenital heart disease, pulmonary disease for children. It's specifically dedicated for children, and I suggest that you take a look at that. I think I'll stop now and let you ask any questions.
Thanks, Dr. Romero. That was a rather complete history, and as somebody suggested, we may need to meditate at the end of it because of the numbers that you're citing. There's a couple of quick questions in the chat that I hope you can address. The first one has to do with the legality of pediatricians providing vaccines to teens above and below 15 years of age who want to get their vaccine, but their parents object to it or their parents are not available. And I don't know if you're back on mute again, Jose.
Let me see here.
No, you're not now. You're good. Okay.
Yeah, I'm sorry, Gary. I'm having, my signal is coming in and out. That may be why I'm breaking up.
Okay.
So the legality of giving that vaccine. So again, in our state, what is indicated is that because it's an EUA approved vaccine, the health department is required to obtain a consent from parents. There is a rule in our state, as you know, that adolescents may acquire vaccines from their providers without their parents' permission. That is an actual consent form. So I think what each provider needs to do, and this is, as a health department person, you should talk with your legal representation and see whether you fall under that ground. That is the shaky ground that you're on. So we know that at least for the health department, we're governed by the request and by the rules of the governor and the legislature. So those children, those adolescents that come to us that are under the 16 years of age need to have a signed parental consent.
And presumably, if a physician chooses to go ahead and vaccinate that person because they're in the hospital or some other situation, they would need that individual to sign the consent for themselves, the adolescent. Would that be your interpretation?
That would be my interpretation if it's the parent, right? But remember, the vaccine, right? We're talking about Pfizer vaccine, and it is EUA approval from 12 years and up, not below that, correct? So I want to make sure that that's what we're talking about. Yes, there would have to be a consent signed by the parent in order to do that.
There's a handful of questions, all good ones from Dr. Ghosh. If you, just to refresh everybody's memories, if you've had a positive test, PCR test or antigen test for COVID, how long do you have to wait before you can get a vaccine?
Yeah, so it's recommended somewhere between up to 90 days. Usually you can get it. I usually tell people 60 to 90 days afterwards. Now, if you're leaving the country, for example, or there's going to be a situation where you won't be able to get that second dose, or you have to get that second dose in under that, then I would start your immunization as soon as possible. So I don't know, you're leaving the country and it's only been a month, then give that vaccine. But ideally, you want to wait as long as possible. 60 to 90 days would be fine. And
that's under the premise that you get a better boost the longer out you are from either the first vaccination or the acute infection, correct?
That's correct. And it's also because if you have a lot of antibody floating around in your body, those spike proteins that are sitting on the surface of your cells are going to be bound up by that antibody, and so you're not going to be seeing as much of the antigen. Right. And along those lines, Gary, if I could just add one more thing, I think we have enough time. Yeah. So the other thing is that's one of the reasons why they're discussing the issue of booster, right? Is because your titers fall over time. So let me make a shameless plug about that. We don't want people going in to get boosters before, whether it's 6 months. And I know there's a lot of confusion, folks, because They're driving me crazy too. First they say 8 months and they say 6 months. And so we're waiting to see what it is. But we want those titers to fall. And we want those titers to fall to a point where you get a nice boost afterwards. And so that's why we're saying, if you got your vaccine in March, wait 8 to 6 months after that. And I'll stop there.
This is a little bit of a complicated question, and it introduces a number of issues you may want to touch on. If you have somebody who's been exposed and had a close exposure, but their initial antigen tests are negative and the patient is asymptomatic, can we go ahead and give the vaccine at that point? And what value would that potentially provide?
Okay, so in that case, is the child still in the incubation period, or is the individual still in the incubation period?
Yeah. And I think the question is, it's sort of post-exposure immunization. Does it have a role?
Yeah. Okay. So the perfect answer would be, you'd want to wait to see if that person actually got infected. So you'd want to wait that 10 to 14 days afterwards with another test or clinically. But if that is your opportunity to vaccinate the patient, vaccinate, right? Give the vaccine. And because we don't know what type of an immune response you're going to get with natural infection, right? I mean, we know that you get antibodies, but we don't know how strong that response will be. It's heterologous. It varies, and the duration may not be completed in 90 days. So I would say give the vaccine in that case. But if you can wait the extra few days and see if the child or the individual has symptoms, do it.
Okay. There was a question about introducing alternative vaccine. I guess this is for kids who might be older than 18 or older than 16, well, actually older than 18. Can you substitute one vaccine for the other? If you got your primary dose as Pfizer vaccine, can you get a second dose with J&J, or can you use it as a booster?
Yeah, so the answer is, the preferred answer is you use the vaccine that you got. So remember, right now, boosters are only being recommended for Pfizer and Moderna. There's consideration for Janssen, but right now, Pfizer and Moderna. So if you have the Pfizer Moderna available, use that one. If you don't, and you cannot wait, then you could use the other vaccine. And the reason why there's a difference is this, Gary, and we didn't get in depth on the vaccines. On that slide that I showed you, and I think you're going to get all my slides, even though I handed them in late. Sorry, but you'll get all my slides. On that slide describing the vaccine, it talked about the vaccine from Pfizer is the receptor binding site. The vaccine uses the whole molecule. So they actually induce different degrees of immunity, right? One does it to the whole sandwich and the other one does it to a little chunk of the whole thing, right? So that's why you really want to stay within the window that you can, so you can get the maximum benefit within the vaccine type that you have, the maximum benefit, okay?
There's a lot of questions about when the vaccine for kids 6 months to 12 years will be available, and I think the answer is no. Do you have anything to add to that?
Yeah, I think I have better data now than I did 2 weeks ago. So yeah, so this is what I heard, and from reputable sources. The vaccine for that group from Pfizer, they will be submitting their data at the end of September. The vaccine from Moderna will be submitting their data mid-October. Now you can begin to calculate when that date will be. It's usually 2 to 3 months after that the FDA issues some type of a recommendation. So 3 months from September, right? 3 months from October.
Really good question. Who should you be testing for COVID? We're headed into URI season. Do we test everybody that comes into the clinic?
Yeah, Gary, that is a great question. And I think it really depends on what you have available to you. I think that until we have really, really good tests that can be done at the bedside or in the clinic, right? A rapid diagnostic test. I think right now you probably need to recommend that only those kids that have significant disease, that have significant symptoms need to be treated, need to be tested at this point. And that's primarily for the issue of isolation, right? And quarantine of individuals around them. It is a sticky situation. This will change. Whatever I told you today is going to change because there are no complete recommendations yet. I'm sure the COID is going to come out on this, right? And then there'll be an AAP statement about it, and the CDC will also. Right now, I think that we're all dealing with the problems at hand and haven't really come to that issue. It's nice if we could, what I'd like to see is some type of a rapid diagnostic test that can be done at the bedside, right, in the clinic, that tests for both flu and for COVID-19. And you get the answer right there. We have a PCR that does that at this time, right? But that tests both for flu and for COVID, but we don't have an antigen test or some other test that can be done at the bedside. But I'm sure it's being developed.
Okay. I have two questions for you, if I may. The first one is, you've mentioned that we're seeing a dramatic uptake in cases in schools. And of course, in those situations, we don't know whether they're school associated or community associated. That said, have we analyzed school districts that have mandatory mask rules versus school districts that don't? If we do have that information, do you think that will be helpful in pushing mandates forwards in school districts?
Yeah, Gary, you still haven't lost your touch for clinical research. That is exactly what we're going to do. So we have a natural experiment, and we meaning the health department. So we capture this data, and we think that by the end of the first month, certainly by the second month, but by the end of the first month, we will have, if there is a difference, we'll be able to see those school districts that have mandatory. And what's more, we can actually do one other thing, Gary. So we can do mandatory, elective, and none. Yeah. Right? So we actually have the whole spectrum. And this will be very similar to what was done in Kansas, right? Where they had counties that had mandatory mask mandates and counties that said no mask mandate. And they were able to show a difference in the degree of infection in those counties.
Okay. A really good question on home tests. Kids that come in with a faint line on their Walgreens Abbott test and get PCR tests that are negative. What is the value of doing those tests? And again, perhaps you can answer for both symptomatic and asymptomatic kids.
Yeah, so that's going to be a big question, right? Especially for the kids that go to school. We're working with the ADE right now, the Department of Education, about what are the guidelines, and it looks like the guideline is going to be that for kids that have these home kits, and after that I'll talk about home kits. We're going to ask that they have a test done either on site at the health department or a PCR test to confirm or to negate the positive test. So if in your case the child did a home test and it was negative, it was positive, but the PCR was negative, he can go to school, no problem, right? Because he got the gold standard, right? If he can't do that, we'll do it at school, right? We're getting ready to set up school testing. And if they can't afford it or they don't want to do it, they can do it at the health department for free. That will count as a real test because it's done by a healthcare provider or elsewhere. Home kits, okay. So we have lost a part of our sight as to what the number of cases are in the state because of these home kits. These are not reportable, so we don't know how many people are actually testing and how many positives we're getting. We do get an idea of the sales, and the sales are up, right? Even members of my own staff who have kids have gone out and bought these things to make sure that their kids, aren't getting infected if they have symptoms. So we're losing our line of sight. And I'm not sure exactly how we're going to go forward on this, but certainly the cases that we're seeing and our ED follow-up Sentinel offices will probably give us information on that.
There was a question about availability of these tests and whether we can get them from the health department, as was the case earlier.
Yeah, so the answer is no, we don't have enough of those tests now to give away. That was a time when we had a whole bunch of them, and the people didn't want them, so they were come and get them if you can. No, we don't have them. The rapid tests, as far as I know, the home kits are available. You can get them. The other ones, I think they're ramping up production at this point to meet the demand, but I can't give you more details than that.
Okay. Another quick question about immunocompromised patients getting the monoclonals. I think you made reference to the Minnesota paper, which gives a list of the categories that would be ideal to treat with monoclonals if they are positive. But one of the questions has come up, since we're in a surge right now, does it make sense to preemptively give monoclonal to kids who are at high risk?
Yeah. So the MMWR actually talks about preemptive therapy. And I didn't get into it because there aren't really good guidelines for kids. So I ask you to go back to the MMWR, and if you don't know which one I'm talking about, I will pull it, make it available to you all for dissemination. But it actually says that you can go back and talk and use it in high risk situations, and they're talking primarily about long-term care facilities, right? So if you're if your relative is in a long-term care facility and there's been a major outbreak, you can use it as that preemptive strike that you're talking about, but they haven't talked about it for other individuals.
Yeah. And I think this is our final question, and we're about out of time. Is a repeat test indicated in a kid who's already had a positive test before they go back to school?
No. That child should serve out their quarantine, right, and then go back to school.
Dr. O'Meara, thank you for your time on Saturday. This has been an incredible review. I think we've handled most of the questions. There's maybe one or two left in there that are buried that we didn't get to, but I think we've answered a lot of questions, and your presentation was wonderful as usual. Thank you so much for the work you do for our state. And my next trailblazing is into retirement, so we don't need you to go there right now, so stay where you are.
Thank you very much. But thank you for the very kind introduction. Thank Anna, Katie, thank you very much for your patience with me as I got this into you. And forgive me if I didn't cover what you wanted me to cover. There's my email address, please. If you have questions, please email me directly. I will answer, and as Anna knows, it may not be until 2 in.the morning, but I'll answer.
Okay.
Have a good weekend all.
We're
And
so
stick
grateful.
around. We're about to go into our business meeting, and I'll hand it off to Anna.
Yes, and Dr. O'Meara, I will just say how grateful we are to have a pediatrician leading our state's charge on addressing COVID. Getting the kind of data you've been able to share with us, et cetera, has been incredibly important and valuable. So thank you so much for all you do and for keeping kids kids as part of the discussion, which doesn't always happen. So we're very grateful to you.
Thank you all for what you do for the kids.
We are trying. So we are now, believe it or not, we are finished with the business portion of our, let me see, hang on, I'm going to